Welcome to the Lifestar EMS Training and Education Center. My name is Todd, and I am glad you're joining me today for a conversation about obstetrics, labor, and delivery. Of all the pregnant women that I have transported in my time who were in labor, they all received one intervention universally, and that intervention was to drive fast, because we're trying to avoid this.
Thanks, guys. Hi, everything okay? Yeah. Freaking believable. She's okay, she's okay. And she's okay on the midline. She's here to have a baby. Oh!
This presentation is going to go over 5 basic topics. We're going to start with just a little bit of anatomy and physiology, a couple terms that you should know when you talk about labor and delivery. Then we'll talk about the stages of labor and what happens at each one of those stages. And then we'll answer the question, is there ever a time that we should not stay put and deliver this baby? Are there times in which you just drive fast even though we're actively in labor? Then we'll talk about the most common complications and some of the things we do to treat those complications. And then we'll go over our protocols, both the current pre-hospital protocols at Lifestar EMS and the statewide protocols that we will be transitioning to. First, just a little bit of anatomy and physiology. We should be aware of a couple of terms. The fundus is the top rounded part of the uterus. We also discussed the pelvic outlet, which is nothing more than all of the bones of the pelvis put together. It forms a ring, and the baby has to pass through that ring of bones. Because they are bones and they are rigid, this is one of the primary sources of complications, getting the baby to fit through that pelvic outlet. A couple of terms that we use when we talk about L&D. Gravida refers to the pregnancy status, and para refers to the number of live births that a woman has given. So when we call in a report and we give the medical history to the hospital, we should be aware of how many times the patient has been pregnant and how many live births she has been part of. Other things that should be included in a medical history, and this is coming out of the statewide protocols that we're transitioning to, would be the length of pregnancy, how many total pregnancies and viable births, we just talked about that, how many non-viable births have occurred, and that is to include abortions, and you do have to ask that question. When was the last menstrual period? The further along you are in the pregnancy, the harder it is going to be for the woman to remember the specifics of that question. The due date is a much easier thing to ask. Is the patient getting any prenatal care? The number of expected babies. And then any drug use, including maternal medication. So any illegal drug use and any prescription medications that the patient is using. These are all important things to include in your history. So when you arrive at the destination hospital, you're going to know what you need to know about this patient. Let's move on to the stages of labor. We talk about 3 stages. There are transitions and phases and so on, but we're just going to stay very general related to EMS. So stage 1 is characterized by the woman in active labor. She's having contractions and the cervix begins to dilate. And because the cervix begins to dilate, she passes the mucus plug, which is there at the opening of the cervix until it softens and expands. The cervix both dilates and effaces. Dilation is the opening getting larger and larger in order to allow passage of the baby, and effacing is the surface of the cervix becoming very thin and pliable. And you are considered fully dilated and effaced at 10 centimeters. Stage 2 of labor starts once the cervix is fully dilated at 10 centimeters, and stage 2 ends with the delivery of the fetus, or now it is a baby once it's delivered. Stage 3 is the delivery of the placenta, and this can take place after your transport. You can give birth and then continue transport to the hospital while the placenta delivers. Sometimes it takes a while, and you may arrive at the hospital without stage 3 being complete. Those are the basic stages. This is just a brief overview of the progress of L&D. An interesting question is there ever a time in which you would not deliver the baby even though you see active crowning or you see active labor, things are getting very, very close to the time of delivery? Is there a time in which you would still drive with the woman in active labor? And the answer to that is there are very few contraindications to delivery in the field. This is based on the reality of once labor starts, it's pretty much going to continue to progress. It is hard to stop. Baby's coming. So you just got to be ready and accept the fact that you really can't stop it if this is going to happen. But one very important contraindication to not transporting, to delivering in place, is a prolapsed umbilical cord. If the umbilical cord is prolapsed, it is protruding from the vagina and the baby's head is not yet crowning, you're not yet at the opening, the danger is as the baby continues to pass through the vagina, it's going to put pressure on the umbilical cord and that's going to cut off the blood flow. So it's very important that if you have a prolapsed umbilical cord, you need to continue driving to the hospital because ultimately the solution to the problem might wind up being a cesarean section. We obviously can't do that in the ambulance. And so you might need to put 2 fingers around the umbilical cord to keep the pressure off of that cord and keep the oxygen flowing until you can get to the hospital. There are, of course, a lot of other complications that can occur during pregnancy. The first one that we prepare for, particularly as paramedics, is eclampsia. Preeclampsia is a condition that is common, particularly earlier on in their gestational period, frequently occurs during the first pregnancy and not so much in subsequent pregnancies. There are a number of other risk factors involved in preeclampsia, but it is characterized by hypertension, really high blood pressure, and protein found in the urine. If they progress from preeclampsia to eclampsia, that is characterized by the onset of seizures. And these seizures are almost always continuous, status epilepticus, seizure after seizure after seizure. The only cure for eclampsia is to deliver that baby. This is from our treatment guidelines. At the EMR level, you provide routine care, place the patient in a position of comfort. We only give oxygen if they are hypoxic, so if they are satting at 94% or above, we don't need to give oxygen. You titrate that out. If you need to assist ventilations, do that. If you need airway adjuncts, you do that. But this is not related specifically to pregnancy. This is how we treat every patient. At the basic level, we can also give glucose if they are hypoglycemic, and you can give glucagon 1 milligram intramuscular, so you can still give glucagon to a pregnant woman. At the intermediate and above level, if the patient is seizing, we can also give Ativan, and if you need to give repeat doses, they ask that you call medical control here. At the paramedic level, we will give mag sulfate. That's 2 grams IV over 5 minutes twice, so that's a total of 4 grams over 10 minutes, and we do that in a IV infusion, or if we cannot get IV access, you can give it IM, but because of the sheer quantity of fluid that you're giving IM, you're going to want to choose a large muscle group, and so our protocols call for putting 5 grams in each buttock. Can give Ativan 0.5 to 2 milligrams either IM or IV, and repeat as needed up to a maximum dose of 8 milligrams. Placenta previa is what happens when the placenta here on the left, which is implanted in an appropriate part of the uterus, if for whatever reason randomly implants and grows and covers the cervix. Obviously, because it's covering the cervix, active labor is going to impact that placenta. It's going to cause bleeding. If you see a vaginal bleed during labor, it might very well be because of placenta previa. Another complication from transporting a pregnant patient can be supine hypotension syndrome, and this occurs when we lay the patient flat on their back, and you see the baby there is compressing not only the vena cava, but also possibly on the aorta as well. And because they're compressing these great vessels in the abdomen, the patient can become hypotensive and they can pass out. So this is why we try to put a patient in a position of comfort and in left lateral position if possible. This helps alleviate the problem of the baby putting pressure on the great vessels. Pre-hospital, we're not going to recognize HELP syndrome, but we may be involved in an emergency interfacility transport of a person who has HELP syndrome. HELP stands for hemolysis, which is the breakdown of blood cells, elevated liver function tests, and low platelet count. This is a combination of preeclampsia with involvement of the liver. This is something that there's nothing we can do for this patient, but it is something that we should be aware of because we might very well be involved in transferring a patient from a lower level LND to a higher level LND because of this syndrome. Shoulder dystocia is when a shoulder of the fetus gets caught somewhere in the pelvic girdle and it is not progressing. It's not allowing the baby to pass through the vagina. It is important to recognize this as early as possible because there are a lot of negative consequences that can occur, and it is also potentially life-threatening to the baby. One of the ways you might recognize shoulder dystocia is the presence of turtle sign. Here's a video that explains it much better than I did.
Fetal shoulder dystocia occurs when one or both shoulders become trapped in the birth canal, delaying delivery of the baby. A common cause of dystocia is failure of shoulder rotation as the baby descends through the pelvis. Depicted here, the anterior or front-facing shoulder has become trapped beneath the maternal pubic bone. In spite of the dystocia, powerful uterine contractions continue to attempt to propel the baby through the birth canal. During contractions, the head of the baby is propelled forward with stretching of the neck, while the shoulders and the rest of the body remain trapped. In between contractions, the force on the baby's body is much reduced, and the baby's head withdraws toward the mother's perineum. This forward movement from the birth canal of the baby's head during uterine contractions and then withdrawal in between contractions is known as the turtle sign and is considered a classic sign of shoulder dystocia.
If you find yourself with a patient in active labor and you suspect shoulder dystocia, there are some maneuvers you can perform in order to try and free the baby from the pelvic outlet. The first of those maneuvers is called the McRoberts maneuver, and that involves moving the patient from what's called the lithotomy position, which is the standard position a woman is placed with her legs elevated up in the air, and forcefully push her thighs back, hyperflexing her legs, which may open up the pelvis a bit, and it may move the pubic symphysis enough to free that anterior shoulder. You can also potentially provide pressure on the abdomen in order to try and press the shoulder of the baby down and free it from that pelvic outlet. Here's a video that shows these maneuvers and also shows a live birth in which you can see them perform these maneuvers.
The mnemonic for the sequence shown here is MAPS. McRoberts, anterior shoulder, posterior shoulder, and salvage procedures. Step 1. McRoberts. Flex the mother's thighs towards her chest to tilt her pelvis forwards while encouraging her to bear down, and apply pressure above her pubic symphysis to push the baby's anterior shoulder away from the midline and into the pelvis. This method is usually attempted first, as it does not involve direct manipulation of the baby. If it is unsuccessful, move quickly to step 2. Apply gentle posterior traction to the baby's head to help deliver the anterior shoulder while continuing suprapubic pressure. Be aware of the risk of Erb's palsy if the brachial nerve plexus is overstretched. If unsuccessful, move quickly to step 3, the posterior shoulder. An episiotomy may be necessary. Insert your hand into the mother's vagina posteriorly to reach the baby's posterior arm and sweep the arm across the baby's chest and out. If unsuccessful, apply traction with your right and left index fingers in the baby's posterior axilla to bring the shoulder down to a level where the arm is able to be swept out, as described before. The anterior shoulder should follow easily. If unsuccessful, try to rotate the shoulders with 2 fingers in front of the posterior and 2 behind the anterior shoulder. Slight rotation may provide space for delivery, otherwise continue rotation for 180 degrees so that the posterior shoulder emerges beneath the pubic symphysis. Rotating in the opposite direction may also be tried. Another option may be to help the mother to turn over onto all fours and to repeat the above maneuvers. For severe shoulder dystocia, which cannot be overcome by any of these routine methods, 3 salvage procedures have been described. For posterior axillary sling traction, fold a 12 or 14 gauge plastic suction catheter over the tip of your index finger, feed it around the baby's posterior axilla, and retrieve the loop with your other index finger. Clamp or hold the catheter ends and apply traction to bring down the posterior shoulder till it delivers or is low enough to allow you to reinsert one hand and sweep out the posterior arm. The second salvage method is the Zavanelli maneuver. Relax the uterus with a tocolytic such as salbutamol or ritodrin, push the baby's head back into the vagina, and perform caesarean section. The third salvage method is to fracture one or both the baby's clavicles with direct finger pressure at its midpoint, thus reducing the breadth of the shoulders. Some of the maneuvers are shown in this case of a mother giving birth to her second child. After spontaneous birth of her baby's head, she developed severe shoulder dystocia. McRoberts maneuver, suprapubic pressure, and posterior traction on the baby's head were unsuccessful. With considerable difficulty, the posterior arm was swept in front of the baby's chest and delivered. This allowed delivery of the anterior shoulder. Further difficulty was experienced with delivery of the baby's body. Despite these difficulties, the time from birth of the head to completion of the birth was within 80 seconds. The baby weighed 3.94 kilograms, with APGAR scores of 5 at 1 minute and 9 at 5 minutes, and no subsequent evidence of encephalopathy or peripheral nerve injury.
We discussed umbilical cord prolapse earlier when we were talking about the contraindications to delivering a baby in place and the importance of transporting a mother in active labor rapidly. This slide shows a description of what umbilical cord prolapse is and the intervention that you perform while transporting the mother to an L&D capable hospital that's able to do a cesarean section is to insert 2 fingers into the vagina on either side of the umbilical cord. This should help relieve pressure off the umbilical cord if the baby's head starts pressing against it. You can encourage the mother to try and resist the temptation to push, although that's going to be very difficult for her, and rapidly transport that patient to that L&D capable hospital. Another complication that we train for is dealing with meconium staining and potentially the more serious complication of meconium aspiration. Meconium is the earliest bowel movement of the infant. Meconium is comprised of the materials that get ingested through the GI tract of a baby that's floating in the uterus. So you'll see skin cells, bile, amniotic fluid, mucus, water, anything that might be floating around can be ingested into the GI tract. Once the baby is born, you'll notice the amniotic fluid has staining to it. It can range anything from light to dark green. If you notice that staining, then you should be on alert for potential meconium aspiration. And the problem is what happens when the baby is delivered and it takes its first breath, it may aspirate that meconium. So what paramedics are trained to do is to intubate the newborn and then insert a French suction catheter through the ET tube into the airway and suction it out. Then we pull the ET tube and re-intubate with a fresh ET tube, suction again, and you repeat that process until you no longer see meconium coming out. Yet another complication is postpartum hemorrhage. It is one of the main causes of pregnancy-related maternal death worldwide. Some bleeding is going to be normal, but when you have that larger amount of bleeding, there are a couple of things that we can do in order to try and reduce that bleeding. First, bleeding is bleeding. It's a hemorrhage, so we want to treat this patient just like we treat any patient that is hemorrhaging. Establish IV access if you can, and administer fluids if you can. The most common cause of postpartum hemorrhage, normally the uterus contracts after the baby has been delivered. So one thing we can do in order to encourage uterine contractions is to massage the fundus. You remember back when we talked about the anatomy and physiology? The fundus is the rounded top of the uterus. You can find the top of the uterus through the abdomen, and you can gently massage the abdomen in order to encourage the uterus to contract, and that can help with postpartum hemorrhage. And the last topic is to take a look at our protocols for L&D and live birth, just to see what our medical director expects of us. At the EMR and EMT level, we provide routine medical care for the mother, and you just treat what you see. If you find a problem, work the problem. As the baby is being delivered, one thing we're encouraged to do is place very gentle pressure on the top of the baby's head in order to prevent what's called explosive delivery, where things rush out too quickly, which can cause tearing and discomfort to the mother as she gives birth. Want to watch that umbilical cord for possible prolapse. Make sure it is not a nuchal cord, which would be wrapped around the neck of the baby. Once the baby delivers, don't drop the baby. And then we want to prevent heat loss, clean, warm the baby, put the baby on mom's chest so that there's skin-to-skin contact, keeping the baby dry. Protect the baby's airway, provide oxygen as necessary. And we want to make sure that you get a 1-minute and a 5-minute APGAR score. We also want to assess the umbilical cord and allow it to continue to pulsate, continue to deliver blood and oxygen to the baby. But once that cord has stopped pulsating, you can wait several minutes longer in order to allow all the blood to drain from that cord and go back to where it needs to be, and then clamp the cord about 7 to 10 inches from the baby and about 7 to 10 inches from mom. And then you can cut cord in between those two clamps and record the time of birth. If you do successfully deliver the baby, you're also going to want to give a call to the hospital and let them know that they have 2 patients coming in instead of 1. Here is a chart of the APGAR score in which we take a look at the appearance, pulse, grimace, activity, and respirations of the baby. We do this at the 1-minute mark and at the 5-minute mark, and we score each one of these categories a 0, a 1, or a 2 based on what we find. It is not unusual for there to be some blueness to the baby. Hopefully it is peripherally and not centrally, but that is very normal at the 1-minute mark. But you should be able to see improvement between the 1 and the 5-minute point, and then you know that the baby's going in the right direction. Thank you very much for paying attention. I appreciate you participating in this training, and I will see you on the next one.